Hello, my name is Nikolai Yusupov. I'm a certified critical care paramedic in New York City, and today I'd like to talk to you about logistics of CareFusion MedSystem 3 infusion pump for the critical care transport. And in this presentation, I'll cover only the most vital aspects of working with MedSystem 3 infusion pump that you really need to know for the duration of the transport. This will be a combination of a PowerPoint presentation as well as hands-on demonstration with the equipment mentioned here. And if you go to my website, criticalcareift.org, I'll have the notes as well as links to all the manuals mentioned here. In addition, you could post questions and comments regarding this video. So I'd like to begin this presentation discussing what critical care transport is all about. And to be quite frank, a large percentage of all critical care transport is about logistics. It's finding safe and reliable securing points for all your equipment. The IV pump, your IV lines, the ventilator circuits, and so forth. It's always a challenge not only to locate those securing points, but to secure your equipment properly and safely. And if you want to have an uneventful trip, you better work very hard in the sending facility to address all those points because you don't want any surprises as soon as you depart the facility. The time to figure out how to use your IV pump or any other equipment for that matter is not by the patient's bedside in the intensive care unit. You should be really proficient and really keen in the knowledge of all your equipment and knowing how to troubleshoot it beforehand and not trying to figure out how things work by the patient's bedside. Bottom line here, you don't want to be jumping around in the moving ambulance, trying to troubleshoot various alarms, resecuring falling devices, especially troubleshooting things that could have been addressed in the sending facility, and not paying attention to the patient during transport. Ideally, all your attention and all the time should be spent assessing patient status, conducting a thorough full physical exam, watching your interventions, and observing patient hemodynamic status. And that time shouldn't be spent fiddling around trying to resecuring falling devices. So this is one of the most important slides I think I have in this presentation, and I want to go point by point and address all of them individually. So upon your arrival in the intensive care unit, introduce yourself, say, hello, my name is so-and-so, I'm a paramedic. Inform them that you do carry your own equipment. You have an IV pump, you have a cardiac monitor, you have a ventilator, and all other equipment that you will require to conduct a safe and reliable transport. Sometimes the nurses or the physicians, they don't really know how the paramedic units are equipped. So the nurse may try to disconnect certain infusions because she is not familiar that you do in fact carry your own pump. So always inform them that you do carry the equipment and you could continue all the interventions throughout the transport. Another thing I want you to ingrain in your mind, healthy patients do not need an ICU. The whole purpose of a patient being in an intensive care unit is that they're not healthy. So get into a habit of getting reports from nurses and the physicians as far as patient's condition in the past 24 hours. Chances are they spend the last several days, perhaps even weeks with this patient. So they're much more knowledgeable and know what's going on with this patient. And they'll tell you much better story if you do ask them to tell you the report. So get into a habit of obtaining trends. And here I have first set of vital signs gives you a snapshot. 2 sets give you a comparison, and 3 sets facilitate trending. And to facilitate trending, you always need 3 data points for you to plot and trend. And that goes for everything that you do. Your blood pressure, your heart rate, your pulse oximetry, your EKGs, even your 12-lead EKGs. And all your ventilator parameters, such as peak inspiratory pressures, plateaus, and everything that you have to get, you always get 3 sets of data points for you to trend. So if the patient is on greater than 3 infusions in the intensive care unit, and you could only accommodate 3 channels as per MedSystem 3, do not rush to ask the nurse or the physician what can you disconnect, for the transport. The only way you could make the determination after assessing all the parameters and assessing all the hemodynamic status updates that you had to get. So get your report from the nurse, ask them their input, output, what's the urine production, how was their blood pressure in the past 24 hours, were there any spikes, were there any dips, Were there any arrhythmias that they had to cardiovert or chemically control? How was the pulse oximetry readings? How was the capnography readings? Get all those data points. And then, only then, once you get your vital signs trending, only then can you make a determination of what you could disconnect. To be quite frank, I'm not really pro in terms of disconnecting infusions for the transport. If you think about this logically, this patient ended up in the intensive care unit, and he's now maintained at greater than 3 infusions. So the chances of you coming in, disconnecting a couple of IVs, and taking home and having an uneventful trip is really slim. And there's much greater chance of deleterious effects happening if you do disconnect certain parameters and certain modalities from this patient. So I try to maintain everything that the patient requires for the duration of the transport. And your goal and your philosophy here should be to conduct ICU to ICU patient care of equivalent or high standards that the patient never feels they have ever left the ICU. So spend that time, conduct a thorough exam, talk to the clinicians present there, get an updated report, observe the trends, and, if you need an extra pump, you could always request, for the company to send you an additional unit, because you rather have everything going smoothly than disconnect a few drips and have a bad patient outcome. All right, so here I'll show you the equipment that I'll utilize for this presentation. Here we have a CareFusion MedSystem 3 IV infusion pump. Here we have a full set pictured on the left, and we have a half set pictured on the right. A BD brand 60cc syringe with 2 IV fluids. Here is a close-up picture of a half set and a full set, and the way you tell them apart is a full set has an administration drip chamber, and it's pictured on the right-hand side of the picture. Here I have a Arrow multi-lumen central venous catheterization set with the 3-way stopcock attached to one of the lumens. And the reason why I have this picture here is whenever you conduct ICU transfers, patients will frequently have central venous cannulation in them, and you need to be really keen and proficient in understanding how these things work. The main difference between a central venous catheter and a peripheral catheter is that the central venous catheter is tunneled into central venous circulation. Hence why you need to employ a sterile technique when accessing any of the lumens here. Because this line is tunneled deep in the circulation, the chances of the patient getting septicemia and ultimately sepsis is really high. So you should wear all PPE that goes mask and gloves preferably. And always speak with the nurses at that facility before you connect your medications to them, because if they're closed, they usually have heparin installation, and the hospital have different policies as far as how to access these points. So some places have the nurse withdraw 5 to 10 cc's of blood prior to specimen collections or connecting medication to the port if it's not being used at the moment in time. So always check with the nurses as far as how to access it. Additionally, if you have different medications going into different ports, ask them the medication compatibility, because mixing certain medications could cause deleterious effects to the patient. So CVC, or central venous catheter, refers to a catheter that is designed for cannulation of the subclavian vein, internal jugular vein, or the femoral vein, and those access points are in relation to the patient's anatomy. Catheters are much longer than the catheters used to cannulate peripheral veins and are typically 15 to 25 centimeters, 6 to 10 inches in length. And this is why I brought up of you wearing proper PPE and really using a sterile technique when accessing these catheters. They're also available with 2 or 3 separate infusion channels. And you'll hear the terms double lumen or triple lumen channel or catheter, which is advantageous with multiple medication administrations and whenever multiple medications are required. The outside diameter of 2.3 millimeters or 7 French and houses one 16 gauge channel and 2 smaller 18 gauge channels. The distal opening of each channel is separated from others by at least 1 centimeter to prevent mixing of infusate solutions. So what this basically says is that Each channel is its own entity, and you could give different medications via different lumens, and they will not intermix inside the central venous catheter. This is a close-up picture of CVC, or central venous catheter, and the reason I have it here is I want to show you that the different gauges and the location, proximal, distal, and medial, are all denoted on the respective ends. So the top one is the proximal, 18 gauge, the one in the middle is the distal, 16 gauge, and the one on the bottom is medial, which is also 18 gauge. And they also differ in length, size, as you could see, and that helps the clinician to determine which one they have to use. Here's a close-up picture with the insert picture to help you differentiate and understand how the catheters actually works. So here we have distal lumen, which is labeled 1, and I'm holding the catheter tip with my hand, and you could see where it's labeled 1. So if I were to give a medication or fluid via distal port, which is brown here, it will come out through port labeled number 1. If I were to give a medication by a medial lumen, which is labeled number 2, it will come out through port number 2. And if I were to give a medication or fluid by proximal number 3, it will come out through port number 3. At the top of the picture, you have a circle and oval shapes denoting the gauges of each cannula here. So the one that's labeled 1, 16 gauge, is the biggest one, and proximal and medial here, which are labeled 2 and 3, are both 18 gauge. Here's a human anatomy chart, and here you have the access points where the central venous catheter actually inserts. So here you have subclavian cannulation, internal jugular cannulation, and femoral cannulation. They could go on either left or right side of the patient. That's based on the patient need or the clinician preference. These catheters are tunneled into the central circulation, and they usually sit in there either in SVC or IVC, and that stands for superior vena cava or inferior vena cava. So the subclavian and the internal jugular would sit in the SVC, and the common femoral would sit in the IVC. Here's a screen that you will see in the intensive care unit, and the reason why I have it here is those central venous catheters are not only used to administer medications, they're also used to transduce pressures. So at times you will see them connected via transducer, which is taped to either a phlebostatic axis on the patient, or they'll be on the pole mounted by the patient's bedside. And you will see a waveform, which is called CVP, central venous pressure. And the waveform tells you the fluid status, or volume load the patient has, and the way it's monitored is via central venous catheter. And as you know, veins are capacitance vessels, and they house the majority of the blood in the human vasculature. So a CVP pressure gives you a rough indication of the volume status. So this is just to give you an idea that those central catheters not only used to give medication, they can also be used to transduce central venous pressures. Here I have a 3-way stopcock, and I'll go in depth of its usage in the video demonstrations. Here we have an Arrow multi-lumen catheter with a 3-way stopcock connected to it, and I have, if you notice, I have 2 other lines connected to the 3-way stopcock, which is then connected to the central venous catheter. And this is done a lot of times to conserve, I guess, port space if you have a lot of medications infusing. So if the medications are compatible and could be administered simultaneously via the same lumen, they could be connected via 3-way stopcock and infused via one central lumen. Here's just a setup that I have: syringe and the IV bags and the pump. This is how I'll conduct my video demonstrations. This is not how you're going to transport somebody in your ambulance. So here I have acceptable transport modalities. So here you have a IV pump mounted on a stretcher. If you're lucky enough that your stretcher houses an IV pole, you could mount your IV pump to the pole. If you do not have the pole, you could utilize the shortboard that I have shown here. The beauty about this is if the patient is peri-arrest, and there's a good chance of him going into cardiac arrest, you have hard surface in the back to conduct good chest compressions. In addition, it works as a IV pump holder, and if you have more than one pump, you could turn the board around and you could put 3 pumps in the back of it. I usually like to take a 3-inch surgical tape and go around the board to connect it to the stretcher. I also tape the pump to the short board to give me a much more secure point. This is just a close-up picture, and I would actually tape over that clamp to make sure it's safe. This is a manufacturer specifications, and this is a direct scan from the instruction manual. And I want to go over the most important aspects here. So the unit weighs 5.1 pounds, including the pole clamp, and depending on the mode you're in, it could accommodate 0.1 to 999 mLs per hour for each channel. This is the battery charge expectancy. So the manufacturer states a fully charged battery has a minimum of 6-hour running time, with all channels running at 125 millimeters per hour and a backlight usage of 2 minutes per hour. The main battery retains 80% of its capacity after 500 charging cycles and retains 90% of its capacity after 3 months of continuous AC charging. So I know that this is rarely the case, and you'd be lucky that you have 3 hours of usage. And truthfully, you should always have the unit charging on AC power when you conduct your transports. And the only time you should be off the AC charge is when you're moving the patients either to your ambulance or from your ambulance to the floor. So this is just a summation of all the important specifications that were shown in the previous slides. So the MedSystem 3 with the pole clamp weighs just over 5 pounds or 2.3 kilos. The instrument combines 3 independent infusion channels, so each channel could facilitate its own rate. It accommodates 20 to 60 cc syringes, and the manual states it's either BD brand name or a monojet. The pump has sufficient pull to overcome the syringe plunger, so do not worry that the plunger will not advance. The manufacturer actually approves its usage and for this modality. And the advantage obviously is less tubing and no IV bags to lug around with you. Rates range from 0.1 to 999 mLs per hour, and this will depend on the modes you're in. So if you're in neonatal mode, it will only go from 0.1 to 99.9 mLs an hour. And if you're going to be like in general purpose 2 or operating room, it will give you a greater range of modes. And I'll have a chart of all those modes in this presentation. As we said, a new fully charged battery, as per manufacturer, provides around 6 hours of operation time with rates 125 mLs per hour. So it's rarely that you have all 3 channels going at 125 mLs an hour. Some may be going at 200 mLs an hour, 100, and so forth. And you could use a backlight display and utilize during programming. So I do not assume 6 hours ever. I always take the AC power cord with me whenever I go to the floor. The reason being, you never know how long the transfers will take. Sometimes there's extenuating delays, and sometimes you may require 2 IV pumps or even 3 pumps. So I just connect them to the wall and I operate off the AC power. And once I'm ready to move the patient, I just unplug them, ready to go. So logistics of critical care 101, I think this point should be taught in all orientation classes. All equipment must be connected to AC power adapters during transport. IV pump, ventilator, isolate, integrated balloon pump. Basically anything and everything that can be plugged into the AC power should be plugged in whenever you're moving in the ambulance. If the units are not being used, they should be on your inverter being charged. So only time the AC power should come off is, like I said, whenever you're moving patient from the ambulance to the floor or from the floor to the ambulance. Important specifications continued. So always power on the MedSystem 3 before inserting the set. Do not insert a cassette into a channel with a service prompt. It needs to be serviced. Ensure the cassette is properly installed before starting infusions. And for IV push medication, the manufacturer states that you have to put the instrument on hold, clamp the tubing above the port, and then push your medication, and then resume your administration. So here I have a picture of AC adapter power cord connection, and a lot of units got damaged because of people inserting these AC power cords with excessive force. And the way you insert them is basically you have to align the pins properly. If you don't, and you just use excessive force, you'll bend them, and then it's basically useless and cannot work. So be very careful how you insert them. There's a red dot on the cord itself, and it has to be aligned with the pins inside that cord and with the IV pump unit. So the red dot is usually pointing straight up at the ceiling, and align all the pins and then securely insert it. It should be flushed against the unit, and the way you know it's properly inserted is you'll see a green status light come on, indicating that the unit is being charged and it's plugged into the AC powder. You also hear a sound beep notifying you that you're in fact plugged it in. So do not use excessive force and align your pins properly. Pole clamp. So pole clamp can be mounted to any device, either a pole, a shortboard, or another device that you may employ. The trick here is once you locate your surface, keep turning the knob until the clamp is tight and pump feels very secure, and then continue turning to make sure the knob clicks and spins freely without over tightening it. So I'll have the close-up pictures here. This is IV pump mounted to a pole on the stretcher. So keep turning it until it clicks and it spins freely and you cannot turn it anymore. This is just another picture of showing you the same connection.